to Shine Veronica Know Everything. We know it's been a while. Today we're going to be jumping into pregnancy and a few things that pertain to this. So to begin with, we have a wheel right here, and this is the pregnancy wheel. So you have 0 weeks all the way up to 40 weeks of pregnancy. And so we cut it into the trimesters. So you have first trimester in green, pink is second, and your orange is your third. So first trimester is between 0 and 12 weeks. So with the first trimester, the blood work that you want to obtain is going to be a CBC. You're going to be doing blood typing, RH factor, RPR, which is your syphilis. You're also going to be doing hepatitis B, HIV, rubella, IgG, and then varicella. There's also going to be some genetic testing done during the first trimester. That's going to be some blood work, which is PAP or PAPPA, and then the beta hemoglobin, or HCG, excuse me. And then you're also going to be doing an ultrasound checking for nuchal translucency. And that's just a fluid that you'll see on the ultrasound. And so we're going to distinguish a few things that occur in specific weeks. So with week 10, you'll be able to find the fetal heartbeat. And then between 9 and 12, you can be doing something that is known as CVS, or chorionic villus sampling. And this is genetic testing. And it's after you find an abnormal screening or test that comes back abnormal. This can also be done for women who are a little bit older, so maybe like above 35, you just want to do that genetic testing. So now moving over to the second trimester. So between weeks of 15 and 18, you're able to do an amniocentesis. This again is genetic testing. This may be recommended if you have an abnormal screening again, or for those older individuals. And then you also want to note that between 15 and 22 weeks, there is another genetic screening that is quad, and that's a blood test. So now we're going to move over, and you can see that between 24 and 28, this is when you're going to be doing the glucose screening for pregnant women. That pertains to everyone. Now we'll move over to our third trimester. So if you are anywhere below 37 weeks, that's considered a preterm. Term is between 37 and 42, and if you go above 42 weeks, that's post-term. And then when you are in this term area, you want to make sure that you get a Group B strep test within 72 hours of delivery. So now we're going to move over here. We're going to be talking about what GTPAL means. So in women that come in typically with any annual screening or any GYN screening, you're going to be asking these questions. So you have G that stands for Gravada, T term, and Gravada just means like how many pregnancies. T term, so if you have like full term or preterm or post-term pregnancies. Oh, sorry, preterm. So they cut that apart, excuse me. Preterm, any abortions and living. So for example, if you had a stillborn, that's a pregnancy, but you do not have any living, so that would be 0. As far as pregnancy changes, these occur in women who become pregnant, so it's not specific women, it pertains to all women, just kind of some physiological changes. So you have a decrease in blood pressure, so you could have dyspnea with that. You have a decrease in your hematocrit and platelets as well. That's because you're sharing them with the baby. You have an increase in white blood cells just by any possible infections that occur, and then you have hypercoagulability. Fundal height is equal to the weeks in pregnancy. So for example, if you get a fundal height of 9, that would mean that you're at 9 weeks of pregnancy. So vaccines during pregnancy, you can get a flu vaccine and then a Tdap. And then common concerns with pregnancy is nausea. So you can give B6 and some Unisem. You can also have round ligament pain. So treatment is going to be Tylenol, or you can have them lie on the side where the pain is. So if it's the right side, have them lay on the right side. And then edema, if that occurs, have them lie on the left side. And that's just due to positioning of the heart and gravity. So now we're going to go ahead and move over to Shannon, and she'll take us through a few things.
So next we're going to be going over teratogens. The definition of teratogens is medications that can cause fetal harm or distress or death. And then we'll be going over drugs that are contraindicated while breastfeeding. So some of the teratogens, one thing to note, if you're not sure, call FAT baby. And FAT stands for 3 to 8, and then baby. This is also known as the pregnancy risk line. They can answer all your questions. So to start, some acne drugs. Accutane causes fetal demise. So we know that's why you have to have 2 forms of birth control. Warfarin causes CNS defects and nose defects. So the best thing if your patient needs a blood thinner is to put them on Lovenox. Misoprostol causes, this is an abortion drug, so of course it's a teratogen. And then another acne drug, vitamin A, which we found in retin-A, causes limb reduction. And then lithium, this can cause cardiovascular effects and lithium toxicity. We know lithium is used for mood, so you kind of have to consider maybe some antipsychotics. Tetracyclines, once again, antibiotic or acne drug. You'd have to avoid teeth staining and skeletal retardation it can cause, so baby doesn't grow correct. ACE inhibitors you want to avoid. This causes skull defects and kidney problems, so you could consider any other antihypertension med like calcium channel blockers, or ARBs, I guess. And then in terms of SSRIs, Paxil's the only one that we think may cause spontaneous abortions. It's not sure totally, but some research is out there, so be cognizant of that. And then anti-neoplastics, this is just a fancy word for chemo drugs. This can cause a spontaneous abortion. DES, this was an anti-nausea drug used in the 60s for pregnant women, which I found out was really bad and caused spontaneous abortions. And then seizure drugs. We have phenytoin, valproic acid, and carbamazepine. I don't know what phenytoin does, but valproic and carbamazepine cause spina bifida, so very bad. I'm not sure exactly what our notes said on seizure drugs. I think it's to limit the seizure drugs and kind of find one that works with your patient, and that's somewhere where you'd have to call Fat Baby and kind of explore more. And then cocaine, benzos, and alcohol, really bad. Fluoroquinolones you're going to want to avoid, so other options would be just pretty much any other antibiotic other than fluoroquinolones and tetracyclines. So like,
Like ceftriaxone or
amyloglycosides, cephalosporins, those should all be okay. So just avoid the fluoroquinolones, which is three fluoroquinolones, Cipro, Levo, and moxifloxacin, so avoid those. So moving on, that was teratogens, do not take while pregnant. Moving on to contraindicated while breastfeeding, a little bit different, not quite as extensive, but very specific. So radioactive isotope, I think that means radiation, I don't know. Chemo, bromocriptine, we know bromocriptine suppresses your milk production, so that's bad. Ergots are the headache medication, something bad for your breasts. Breastfeeding, lithium, the mood drug, bad for both. Amio, it's an antiarrhythmic drug, so you'd have to consider another antiarrhythmia or just kind of restarting the heart. Codeine, cough syrup, do not take. And then galactagogues, these aren't contraindicated necessarily, but they're kind of bad. These are milk producing drugs, and we think that these have limited research. So moving on, pregnancy complications. So early on in your pregnancy, up to 20 weeks, you can have pregnancy loss, which is either ectopic or spontaneous abortion, which we call miscarriage. The reason it's up to 20 weeks is that after 20 weeks, 20 to 28, we call it a miscarriage, and then after 28, it's just preterm. So an ectopic pregnancy is when the pregnancy implants outside the uterus, usually in the uterine tubes, and then this can rupture. So that's kind of an EMS finding, a ruptured ectopic pregnancy if they have very severe acute abdomen. So the way we diagnose this is you go do an ultrasound, there's nothing in the uterus, and there's an adnexal mass. So you can treat this surgically or medication. Meds is methotrexate. You just do steroids to kind of get her done. And then laparoscopy, so you go in through the laparoscopic surgery through the abdomen. So next we have spontaneous abortion or miscarriage. This is a pregnancy that ends less than 20 weeks, like I said. We have 5 types. Incomplete, inevitable, missed, threatened, incomplete. So I'm going to go through what the cervical os looks like during these pregnancies or after, and what the product of conception looks like. So I remember the 2 eyes are when the cervix is open, so keep your eyes open. Incomplete, the cervical os is open and you have some delivered. So it's an incomplete miscarriage because you have some of the fetus delivered, but you're still retaining some of the product of conception in your body, so you need to go and do a D&C. Inevitable, your cervical os is opened, but it's not delivered. Missed, closed, and no delivery, and threatened is closed and no delivery. The difference between missed and threatened is that missed, the baby is inside you, or the fetus is inside you, but it is dead, so you need to go in and scrape it out. Sorry, I probably shouldn't be saying that like that. You need to go in and do a D&C, apologies. And then threatened, the pregnancy is threatened, but it's still potential that the fetus is going to be viable. So closed and no delivery. And then a complete is the cervical os is closed and you have a full delivery, so that's a kind of traditional full miscarriage that we think of. So treatment for miscarriages, we have first trimester treatment, which is more common, 0 to 12 weeks, and then second trimester miscarriage, which is less common, 12 to 20 weeks. But a missed or inevitable, you're going to go and do a D&C. So because no product of conception was delivered, you need to go and do a full D&C. Threatened, just do pelvic rest, so no sex, nothing in the vagina, so that we can make sure the vulnerable fetus is still going to be able to carry to pregnancy. And then incomplete, you can either do meds, which help contract the uterus, or you can go in and do a D&C to get the rest of the product of conception. So then if it's a second trimester, a little more developed, you're going to just either go ahead and deliver the fetus or go in and do a D&E, because we know D&C is first trimester, D&Es are always second trimester. And then as I said, 20 to 28 weeks is a stillborn. So next is diabetes. We have gestational and pre-gestational diabetes. Gestational diabetes is when you have never had it and you get diabetes while you're pregnant. Pre-gestational is you have diabetes and then you get pregnant, so it's called pre because you had it prior to your pregnancy. So gestational diabetes we diagnose with a high HPL. This is an anti-insulin marker. And then glucose intolerance appears at 24 to 28 weeks. So that's when we screen for gestational diabetes, if you remember the wheel. So it's really not until the very end of the second trimester that we're starting to be concerned about this. So neonatal complications of having diabetes once you become pregnant is macrosomia, which is a baby greater than 10 pounds, and then associated with that, birth injuries. So like I said, the screening is 24 to 28 weeks. You're just going to drink a glucola. So some women will say, oh, when do I have to drink the sugar drink? And you'll say, oh, at the end of second trimester, so about 6 months in. And then that's the screening. This is the diagnosis, the 3-hour glucose tolerance test after 8 hours of fasting. So treatment for gestational diabetes is diet, metformin, insulin, and then you'll have the patient after delivery follow-up 6 weeks postpartum and yearly thereafter because they have the increased chance of having diabetes. So pre-gestational diabetes, you have it before pregnancy and it continues. Complications, there's a lot of complications for this. Miscarriage, preeclampsia, some fetal complications. Once again, macrosomia and the resulting birth injuries, which may be a traumatic brain injury because the baby's head isn't getting out of the way. Shoulder dystocia, where their head comes out, but then their shoulder gets stuck because it's really big. And then Erb's palsy, where your arm is adducted and anterally rotated, so the baby's head comes out and the arm gets stuck and they have a brachial plexus injury. So treatment for diabetes, pre and gestational, 3rd trimester, we're going to do fetal surveillance ultrasound. Just keep an eye on the baby. You don't want them to get too big, so deliver by 38 to 39 weeks. And then glucose control in labor with insulin and glucose strips. Okay.
All right, I'm going to go ahead and just finish this off by going over hypertension in pregnancy and infections in pregnancy. So we'll start with hypertension. We have 4 different categories, so we'll begin with chronic. So this is hypertension that occurs before conception or before 20 weeks gestation, or it persists 6 weeks after delivery. And the value is going to be greater than 140/90. Gestational, so this is diabetes that occurs during gestation or while you're pregnant. So you have the hypertension values, but there is no proteinuria and there's no edema of the patient. And then you just follow guidelines for hypertension. So we have preeclampsia. So there are 4 categories somewhat in here. So first we'll begin with mild. So the individual has hypertension, but it has non-dependent edema, which typically you see edema in the extremities, but with this you just have it in the hands and face. There is proteinuria present in this patient. As far as management, if they are greater than 37 weeks, you want to go ahead and induce them so that they deliver. If they're less than 37 weeks, you want to do bed rest and betamethasone. And again, the value is just 140/90. So then we also have this severe type, which is broken down into 3 categories. So you just have severe, which is oliguria, you have pulmonary edema, thrombocytopenia, proteinuria. And then we have another thing considered HELLPS syndrome, which is right here. So you have hemolysis, you have increased liver enzymes, and you have decreased platelets. And then you have eclampsia. So this is going to be a grand mal seizure. Management is going to be hypertension control, magnesium sulfate, and for the seizures, and then you want to go ahead and just deliver the fetus at that time if possible. So then we have a superimposed
Pre-eclampsia on chronic hypertension.
Pre-eclampsia on chronic hypertension. So this is somebody who previously had chronic hypertension before getting pregnant, and then they also have a very increased proteinuria. So that was hypertension in pregnancy. Now we're going to go ahead and do infections. So we have 4 different categories here. The first is going to be common infections that are made more concerning in pregnancy. So the first one's going to be a UTI, a urinary tract infection. So what you want to do is you always want to treat asymptomatic bacteriuria. So say somebody comes in just for a normal exam, you do a UA and it's positive, just go ahead and treat them even if they're asymptomatic. And then you always want to culture the urine regardless if this is their first one or not. And then you always want to treat for 10 days. And then along with that, pyelonephritis is also concerning in an individual who's pregnant. So 15% of those individuals will develop complications. So you want to go ahead and just admit them to the hospital, make sure you give them IV hydration, IV antibiotics, and then you also send them home with antibiotics for 10 days just to ensure it doesn't lead to any complications. So the next category is going to be infections that are specific to pregnancy. So group B strep, and we mentioned that you want to test that within 72 hours of delivery, as it can be risky for the fetus. And then chorioamnionitis. Chorioamnionitis. Anyways,
I don't know.
so this is just an infection of the placental membranes and the amniotic fluid. So you're going to find that the mother is going to have a fever, she's going to have uterine tenderness, the fetus is going to have tachycardia, and there's going to be increased white blood cells. So treatment is going to be antibiotics and you want to deliver immediately. Infections that can affect the fetus, so this is going to be herpes, varicella, rubella, HIV, and toxoplasmosis. And then just some other pre-existing maternal conditions that can affect the fetus, so seizure disorders. Shannon kind of went over how those meds can be teratogenic, and as you can imagine, that's not safe for the fetus. One thing to recommend if somebody does have a seizure disorder is that they start taking 4 milligrams of folic acid prior to conception. And then cardiovascular disease and thyroid disease. So that covers a lot for today. Thanks for tuning in. Don't forget to like and subscribe.